Excision, nasal polyp, S. Simple. The area is approached intranasally. Topical vasoconstrictive agents are applied to the nasal mucosa. Local anesthesia is injected underneath and around the polyp. A scalpel or biting forceps excise the polyp. Small polyps may leave mucosal defects that do not require closure. With larger defects, the mucosa is closed with sutures in a single layer. Excision, nasal polyp, S. Extensive. Large polyps are removed with a wire snare stretching the polyp base. The physician may place telfa to pack the nasal cavity during the first 24 hours. Excision aural polyp. Through the external ear canal opening, the physician removes the aural polyp with a cup forceps or an ear snare. Bleeding is controlled with packing or epinephrine on a cotton ball. Antibiotic drops may be instilled. Excision of infected graft, neck, extremity, thorax, abdomen. Through an incision in the skin overlying the graft, the physician dissects around any muscle, vessels, or other structures to access the graft site. The physician excises above and below the existing infected graft. The blood vessel is repaired with sutures. A catheter may be left in place to help drain infection. The skin is loosely closed. If the excised graft is replaced with a new graft, report the appropriate revascularization code. Excision of fibrous tuberosities, dentoalveolar structures. The physician excises fibrous soft tissue overlying the tuberosities of dentoalveolar structures, reducing the size of the tuberosity. The physician makes wedged or elliptically shaped incisions through the soft tissue of the tuberosity. The tissue is removed and the surgical wound is sutured directly. Excision of osseous tuberosities, dentoalveolar structures. The physician removes the osseous tissue from the tuberosities of dentoalveolar structures, producing more favorable bone contours. The physician makes an incision through the mucosa of the tuberosity and exposes the underlying bone. Drills, osteotomes, or files are used to remove and contour the bone. The tissue is sutured directly over the bone. Some soft tissue may be excised prior to closure for adaptation over the newly contoured bone. Excision of hyperplastic alveolar mucosa, each quadrant. The physician excises hyperplastic or excessive mucosa from the alveolus. Incisions are made in the hyperplastic tissue, separating it from the normal mucosa. The excessive tissue is removed. Excision of single external papilla or tag, anus. Excision of multiple external papillae or tags, anus. An incision is made around the skin tag or papilloma and the lesion is dissected from the underlying sphincter muscle and removed. The incision is closed with sutures or may be left partially open to drain. Excision external ear, partial, simple repair. The physician removes a full thickness section of the external ear, often as a triangular wedge. A small portion of normal tissue surrounding the defect is removed. The wound is closed with layered sutures. Excision external ear, complete amputation. Using a scalpel or electric knife, the physician amputates the external ear. The wound is closed during a second procedure involving a skin graft or flap. Excision inferior turbinate, partial or complete, any method. The physician removes a part of or the entire inferior nasal turbinate located on the lateral wall of the nose. The physician places topical vasoconstrictive drugs on the turbinate to shrink the blood vessels. A mucosal incision is made around the base of the turbinate. The physician fractures the bony turbinate from the lateral nasal wall with a chisel or drill. The turbinate is excised. Electrocautery may control bleeding. The nasal mucosa is sutured in single layers. The nasal cavity may be packed with gauze. Excision or surgical planning of skin of nose for rhinophyma. The physician surgically removes diseased tissue caused by rhinophyma from the external nasal tip. Local anesthesia is injected into the nasal tip. The excess tissue is removed by carving and recontouring hyperplastic tissue from the area. Scalpels, dermabrasion, planing with fine sandpaper or wire brushes, and lasers are common methods of removing this excess tissue. How do I report CO2 laser treatment of the nasal surface that was performed in conjunction with a shave biopsy and dermaplaning for rhinophyma? Code 30120, excision or surgical planning of skin of nose for rhinophyma, includes all maneuvers for use of the laser and knife blade. Therefore, the CO2 laser treatment and shave biopsy are considered inclusive components within Code 30120. Excision of tonsil tags. The physician removes portions of the tonsils not excised during primary resection or that have developed polyps. The physician cauterizes and slash or snares the affected tissue. No closure is required. Excision of ampulla of fata. The physician excises the ampulla of fata, a saccular dilation of liver and/or pancreas. The physician exposes the duodenum and pancreas via an upper midline abdominal incision. The duodenum is opened with a longitudinal incision. The ampulla of fata is exposed and the abnormality is excised. The common bile duct and duodenal mucosa are reapproximated as needed. The duodenum is closed with transverse interrupted sutures.